I'm your host, Dr. Dean Mitchell. This is a question for my listeners. Have any of you experienced where you keep on getting sinus infections over and over again? Which doctor do you go to? Do you go to your primary doctor and get another round of antibiotics? Do you go see a specialist? Chronic sinusitis is a debilitating condition for thousands of Americans. It's also a condition that's not well understood by doctors. That might be surprising. ENTs and allergists are the specialists that tend to care for the chronic, complicated cases of sinusitis in hoping help these patients get better. The current evidence is leaning toward chronic sinusitis not being due to bacteria. So, in essence, this makes antibiotics superfluous. And it seems more likely it's due to some type of chronic inflammation that could be allergic or it could be fungal. Now, regular listeners of the podcast know that my background, I'm board certified in allergy immunology. So I'm hoping to have a really spirited discussion today with a colleague of mine I've known for over a decade, Dr. William Reisiker, a well-respected ENT here in Manhattan. Dr. Reisiker is a professor of otolaryngology and a director of the allergy services at Weill Cornell Medical College. He is also the founder of several healthcare companies, which we'll talk about. I'd like to note also many ENTs, their training is surgical, so they're focused on surgical treatments for sinusitis. And I think a lot of them treat allergy as a hobby. Dr. Reisiger, I believe, is really serious about allergies. And the only hobby that I'm aware of that he does is that he's a stand-up comedian. And unfortunately, I haven't gotten to see him perform in quite a while because of COVID. I've known Bill for over a decade, and I consider him a compassionate, thoughtful doctor whose opinion I do greatly respect. So, with that, I'd like to welcome Dr. Bill Reisiker to the podcast.
Dean, thank you very much for having me. It's an honor. And I haven't seen myself perform that much either because of COVID, sadly.
Well, maybe you're practicing your sets before before this whole thing blows over, which has been quite an experience for all of us. So,
Yes.
all right,
Yes.
I'm going to start off with a little bit about your background, and then we'll get into some of the medical issues because I'm always interested in specialists that I interview. And as I just mentioned, many ENTs, I've been to meetings. I actually have attended in the past the Otolaryngology Allergy Society, and I always got the feeling that allergy was sort of a side issue for ENTs, even though they see a lot of it obviously in their practices. I was just interested in what got you focusing on allergies in your career. And was it from like personal experience, or was there a mentor, or what kind of got you involved?
Agree. That always struck me as funny too. It seemed like allergies were like the Rodney Dangerfield of the ENT world. Just got no respect. But yeah, I came to it from a variety of things. Definitely, there was some personal experience that I had with allergies, particularly food allergies. I'm severely peanut allergic.
Oh, wow.
But when I first went into practice, I started out in private practice. So I made the unusual transition starting out in private practice and going to back into academics
Right.
about 5 years later. But where I was practicing up in the Hudson Valley, beautiful area in New York, but it is a hotbed for respiratory allergies. So I was treating all my sinusitis patients and doing surgery, and I thought I was the greatest surgeon in the world, the doctor in the world, but people were still coming back with problems. And then I eventually came to the thought, well, people have allergies, and I wanted to send them for evaluations. And I said, listen, let's just start adding this to my practice. So I went back in, I did more training and really sort of did a deep dive into how to do testing and immunotherapy. And it just completely changed the whole face of my practice for the better.
Oh, that's interesting. Yeah, I have to believe also, yeah, a lot of ENTs, are open to it, realize that inflammation and allergic inflammation is a big part of what they're seeing. And yeah, obviously, and we'll talk about this in appropriate cases, can really make a huge difference. But again, when you have people coming back, even after having multiple surgeries, as you and I have both seen in our practice, you start to wonder, is it good to keep on going in there and, doing procedures?
Absolutely. Yeah.
Yeah.
To the point, you were mentioning how many things I think now are causing sinusitis. It's not just bacteria, but it's many things. People ask me what causes sinusitis, and I'm like, yes, well, it's all those things. It's allergies, it's fungal, it's all the irritants that are in our air, along with infectious virus, bacterial products. So it's all out there, and it all is a mixed bag. Yeah.
Let's go. We're going to go to the medical approach now a little bit. This is the part that I want to find really interesting because, give us as doctors, we sort of a little bit in silos, seeing our patients, doing what we're comfortable with, hopefully getting a little better at certain things. So when you see a patient, let's say a patient comes to your office and is referred by one of the internists at Cornell, and the patient's had 5 or 6 sinus, supposedly anyway. I want to say, let's say sinus pain over the last 2 years or so. What's your approach? And can you give me like how you see those patients? Obviously, like your type of, and what find that you think the other doctors might have missed.
Yeah, sure. That's always difficult when we're seeing patients who have been to different hospitals, different doctors, that sort of syndrome, many
Hmm.
treatments, many failures, is always very difficult. But really, the key is taking a really detailed history. And that's where it's so hard because we don't have as much time. We never have enough time with our patients. But that is truly the key to diagnosis. All the fancy tests we have, CAT scans, MRIs, and really, if you can find out about that patient, when they experience their symptoms and what they've done for it in the past, you can really tell a lot about people. Where is their pain coming from? Is this an infection, or was it maybe not as many times an infection as they thought?
That's a great point. I hope our listeners really appreciate that. And, unfortunately today too, I'm going to have to tell a quick personal story that's going to really relate to this because as you mentioned too, yeah, a lot of doctors are under the gun and having to see patients quickly, and especially surgeons, days that they're operating, other days they're seeing a lot of patients. And a personal story, I had a family member, it was really quite interesting, who developed a severe chronic pain and discharge. Never had it his whole life, and it became quite severe. And he saw in his area several nose and throat doctors. They scoped him multiple times. Up doing a CAT scan. That's what I was going to talk about the CG diagnostic testing. And showed all his sinuses were filled up. They gave him a round of antibiotics. You're familiar with all this, obviously. They gave him a round of antibiotics, didn't do it. Another round of antibiotics with steroids, still didn't get any better. And then what typically happens is Dr. Dean had to get involved. You try to stay on the sideline a little bit when it's a relative, but sometimes you just can't. And I knew the personal history. And what I didn't know was that, and this was really fascinating, Bill, this been water damage in his apartment building where he was
Mhm.
living. The floor was literally bursting up. Family members had noticed there was a problem, but they kind of for about several months or a year. And then all of a sudden, the floor just basically exploded. And it was because the building was doing work outside, water seeped underneath, and of course, there was mold.
Yeah.
And that became, we'll talk about this after, a huge problem. And as I said, after seeing multiple T specialists, well, and a few of them, I know one of them, because then he went down to Florida for a while, threw her hands up, like, I don't know what to do. And I started getting involved. We'll talk about this a little bit later about how to treat mold because it's really tricky. It affects a lot of areas, but the sinuses are clearly an area problem. But just to get back to diagnostics, you feel in those kind of cases, I'm sure you've seen them, but that a CAT scan or an MRI is really important to see how extensive the disease is.
Yeah, when it starts to get into the category of chronic disease, where you're seeing things that are not resolving after an appropriate amount of time, and you've
Right.
you've treated them medically, imaging is a big part of that to see structurally what's going on inside the sinuses. I think doing that early on in the very acute or the very early stages of the disease, that's probably not as helpful.
That's a good
But
point.
absolutely, you need the roadmap
I mean, if it's more
to
than
see the
3 or
result.
6 months, yeah, I think
Oh, sure.
that's almost like definition. I think it's a good point, and a very good point about not doing it too early because you're gonna miss something. It takes time for these changes to, really occur.
Exactly.
What would you say, I know I have my thing. What would you say are the 3 biggest factors that lead to, chronic sinus cases? I mean, they that go through your mind, you're seeing a patient.
Yeah, I think definitely anatomic issues are a big part of it. Some people
Sure.
just have drainage pathways or other conditions like polyps that are inside the sinuses
Right,
or on the outside of
absolutely.
the sinuses. That's a big one. I think chronic inflammatory is big, whether that be allergic or what we call non-allergic, which is just kind of a inflammation from all the chemicals, odors, pollutants, particles that we experience in the air. And of course, you have all the infectious components, which we've grown to appreciate infectious agents now over the past year and what they can do to us. So that I think those are probably the biggest factors.
Yeah, you just answered my list here. And third one I just wanted to mention because I know ENTs were really big on this for a long time, and I don't know if it's ever really been fully proven is the whole idea of the gastric reflux.
Hmm.
And do you find that in your patients, or do you think it's more a minor thing than some of your colleagues may? A lot of times, a lot of doctors when they don't, well, typical thing too from an ENT when I see the patient, it's evaluate the structural. So if they don't think there's something operable like polyps or whatever, they rule that out. If they do an allergy testing or do an bloods and that's all negative, now they're really getting frustrated. So
Yeah.
then of course they're like, okay, reflux, a little bit of and interesting. I take a little bit of a different twist on it. I think if people's microbiome is off, that to me would alert me more. But have you found like the reflux ever any pretty dramatic cases with the sinusitis resolved or?
Yeah, it kind of go back and forth. Acid reflux actually triggers sinusitis, or which is causing which. Definitely, there is a large overlap in people who have these conditions, and a lot of that can be symptom overlap as well. For example,
Mm,
people with acid reflux have a lot of post-nasal drip because the body is trying to neutralize all these acids that are getting up into the throat and even potentially into the back part of the nose.
yeah.
So you can get a lot of symptom overlap from it.
Mhm.
I definitely pay attention to it. People who have chronic sinusitis end up taking a lot of antibiotics and steroids. And if anything, it'll
That's the
give you a
nightmare.
reflux.
I
Yeah.
I also do holistic medicine, and what I've
Oh,
really found, we'll get to this also after on too, actually the next question. You have to deal with the microbiome issue. I think more and
yeah.
more we're starting to realize. I deal a lot also with a lot of kind of rashes, especially the hives, the urticaria rashes.
Yeah.
Dermatology colleagues are amazed when I'm able to help some of these patients by rebalancing their microbiome,
Yeah.
because antibiotics is, unfortunately, a good thing got turned into a bad thing in a lot of cases.
Yeah.
So to get to the question of how you treat, let's say again now a patient is looking for help from you. They travel to the Upper East Side, coming to see the Professor Reisiker, and they're like, "What are you going to do for me?" I don't know. Do you find the nasal steroids, the combination of decongestants, the things that I like a lot? I'll be honest with you. This was magic for this relative of mine was, believe it or not, the Nevada machine. I don't know if you're familiar with it. It's
Yeah.
basically like a fancy neti pot, but it really works
Yeah.
amazing. You fill it up with distilled water. It has a special hypertonic
Yeah.
saline packet in it. I put a couple other special ingredients in, and this thing shoots up into the
Yeah.
nose like in
Yeah.
30 seconds and rinses it out. And I don't know. I think sometimes
I,
the irrigation is important. So
I
what
tried
do
that
you
on
like to
myself
use?
actually. A little while
Yeah.
back, I could not stop laughing. To be honest with you, it it sort of tickled the inside of my nose. I was
Oh,
I was like
really?
rolling on the floor,
I
hysterical.
thought you told yourself a joke or something. I mean,
No, no, no. So
no.
listen, even if your patients use it, they still have sinusitis, but they're going to be just totally tickled pink. You'd really be happy. Doesn't matter. They won't
Yeah,
care anymore that they have
that's
sinusitis if
right.
they use that.
Honestly, though, to talk about the sprays, sprays
Yeah,
are a big deal. I mean, obviously, it's easy to use. Obviously, if they're shown correctly, which I always emphasize to patients, make sure you're pointing it toward the outer aspect,
yeah,
inside the nose, not to the septum. You're just going to get a bloody nose otherwise.
yep.
But do you like any of them, Nasocorts, the Flonasers, or even versus the antihistamine ones, the Astelins? I mean, just, again, I want to learn from you. What do you, anything that you find to work a little better than others or safer than others?
Yeah, in terms of the nasal steroid sprays, I definitely go to those very often, particularly in my rhinitis patients. You have them use at least for a period of time to use the steroids. I tell them to use that like a foundation of their house. That's one that you use every day, not forever, but for a period of time. And then on top of that, you build in more of the as needed medications, and that's where the antihistamines come in, either spray, tablet, eye drop, and of course the other things like saline, which you mentioned, which I think is very underrated. It's a huge go-to for me.
It
It's
is,
very
right?
safe. It
Hmm.
can have lots of benefits.
Yeah.
Like say, I learned in my surgical training, the solution to pollution is dilution,
I
and I
like
use
that.
that
That's
a
a good
lot.
one. Just one thing on the decongestants, though, which sometimes you need them. And I find that the antihistamines are a little bit useless in a lot of these patients. Again, it's a very strong allergic cause. And I do worry. I've always cautioned a lot of my patients to avoid the combined antihistamine decongestants, especially for a long period of time, like Claritin D, Allegra D, Zyrtec D, because I've seen a lot of them where even young patients, their blood pressure starts to rise, especially the diastolic. But it's tough. I'm just really tough getting these people relief. And so the sinuses are very. I always like to make the analogy to patients. Trying to explain to them how we want to get flow through there. I said the reason, unfortunately, sinuses tend to get infected. It's like a comparison of like an ocean and a small pond, right? The ocean,
Right.
unfortunately, you can pollute the ocean, but the circulation, the movement, everything gets swept out. Where a small little pond, which is like when you see a picture of a CAT scan of the sinuses, things can just really fester there, right?
Yeah, the areas they need oxygen, they need airflow, and
Yeah.
that's why people have had inflammation over such a long period of time. The tissue has actually become sort of in place.
Mm,
You can throw as many steroids as you want. You're not going to get those tissues to go down in size and to get those sinus passageways opened up. And that's where, unfortunately, sometimes it requires some surgical intervention just to get
sure.
the oxygen back into those spaces.
Right, right, right.
Oh,
When I always tell people when the roads are all blocked completely and they just don't respond,
right.
you got
I mean,
to,
there's no magic to it, but
yeah,
what I like to describe to the patients who have to go for surgery is that do surgery to help the medications work a lot better.
good point.
Magic to surgery itself, but it really does help a lot. Medications alone aren't doing it, and you need something else.
Let's talk a bit about surgery, and then we're going to get to allergy, which you and I both have
Mm.
obviously quite a strong interest in. But what used to be the bane of, I think, even the ENTs, and was for allergists, is when patients had recurrent nasal polyps. It used to just be awful. I think you feel so badly for these patients. I mean, COVID patients can relate to it because these people can't smell or taste their food.
Right.
Just they really are miserable. I just remember some just really cases of this, and they would have to go on rounds of oral steroids in addition to their nasal steroids just to be able to taste their food for a couple of weeks, and then they were
Right.
back to where they were. Do you think, I'm just curious, the role of surgery in nasal polyps, and also maybe we'll talk a little about the new biologics, which are quite interesting. Like, and so,
Mhm.
just give me the latest, what you guys are finding, treating these patients that seem to have these, especially recurrent severe nasal polyps. What are you doing
Yeah.
for them?
You think nasal polyps are fascinating and frustrating as it comes. What we're realizing too is that not all nasal polyp patients are the same.
Oh, okay.
Some patients you can take out the polyps and they stay good for years and years. Whereas some people, the time you got them back to the recovery room, they've already recurred.
It's
The polyps
horrible,
have already come
right?
back. So I think we're learning a lot in the genetic area, in the area of epigenetics.
Mm,
It's heritable changes that occur to our bodies. Things that you can pass down actually that occur to you during your life, and people who have underlying genetic conditions called barrier defects, epithelial barrier defects. So the skin inside the nose just allows for more inflammation. Some of those people have a much more difficult time with their polyps. So I think it's becoming more personalized as we go, and definitely as we move into the future. The treatment of nasal polyp patients is going to be different based on what they're bringing to the table.
okay. Patient does require surgery. That tends to have to be a more invasive, complicated procedure, right? I mean, I'm familiar a little bit with sinoplasties. I know a lot of ENTs were doing it the last probably decade, and it seemed like it was more of a minor, quote, minor procedure, even though I had a really great doctor mentor who always told me that minor procedure is always on somebody else. But
It's
what
minor until it happens to you, right?
right. What do you think about the range of procedures? I mean, also, and are a lot of places, say Cornell, are they doing it a lot differently than at Mount Sinai? I mean, really like a lot of different schools of surgery, so to speak, being done.
Yeah, I don't think there's drastic
No.
differences when you go, particularly in the same city. You always go for complete removal within the bounds of safety.
Right.
Of course, safety is the top priority, so you don't want to jeopardize a person's ability to smell.
Right.
You try to remove a couple of last polyps that are difficult to remove. So you want to do it as completely as possible, yet safely as possible. And thank goodness we have new instruments and new technology that's out there using navigation systems that allow us to really have an accurate roadmap of where we are, where we're getting close to certain structures. So that's been a real
Mm.
benefit.
Are they doing any robotics for this kind of thing or not yet?
Robotics institution, not for polyp surgery, not yet. That hasn't reached the mainstream. But who robotics is going to
Yeah,
do?
I mean,
I'm
it's
trying to develop a robot who can give allergy injections to my patients. But who knows
well,
what the
thank God I
future
do.
holds?
We're going to talk about. Thank God I do drops. Otherwise, I'd really be in trouble because the
The-
robot would take my place. I heard about a robot,
exactly.
patient prior to COVID, like a year before, who came back, and I forgot what we were talking about, but she said they have robot dentists there, and I was like, what? I don't know. I don't think New Yorkers are going for a robot anything doctor
No,
dentist yet.
I'm not.
What?
I'm not ready for that. No, I'm not
Yeah.
ready for
What? Yeah. They at least want somebody who has a sense of humor.
that.
What do you think about the biologics? Like, Dupixent, I heard from, colleagues, feel like a lot of these biologics are really quite good at polyps from recurrent. Are you using it in your practice or?
Yeah, in our practice, yes, we do use the biologics, and I think it's an amazing new tool that's available
Hmm.
to work really well. Nasal polyps, definitely for allergic rhinitis and a whole host of other inflammatory conditions, asthma, eczema. It has really, I think, changed the game and changed the landscape.
Yeah.
I think I move forward with any new technology. There's always some debate back and forth. Where exactly does that fit into my practice? Do I start something like that early on in
Yeah.
therapy? Do I start it, by surgery? Do I do it in
Right.
between? Do it. So I think that the debates rage on, how to integrate it into the practice. But those are just wonderful tools that are out there
Yeah.
now.
A lot of patients also that I see, again, doing some of the holistic, they're really a little bit reluctant, which I understand because these are powerful medications. And how long can you take them for without some other type of immune
Right. Of course,
suppression?
yeah, their expense, they're
Yeah,
expensive,
sure.
sometimes not always covered by
Yeah.
insurance,
Hmm.
and do have some risks, of
Yeah.
severe reactions. So always
Hmm.
have to take that into mind as well.
Well, let's talk about something that you and I both have a keen interest in sublingual immunotherapy. I think it's really
Okay.
how we ended up connecting. I remember this is kind of funny actually. Once, a lot of my listeners and patients know I was doing sublingual allergy immunotherapy over 20, it's probably now 25 years. And I was just really fortunate to get into the field. And I was like really alone. I was the only allergist I know in New York at the time that was doing it. There really weren't even ENTs that I knew were doing it. And then I think one day, I think I saw you on TV. And maybe there was a thing, and it was like a bad season like we're having now. And all of a sudden, they said, a doctor doing sublingual allergy drops with patients. And I'm like, oh my God, I'm not alone. Because that was always the question I always got from patients. They were like, how come you're the only one doing this? They thought there was something nefarious about it. I
Right, right.
said,
It was
no,
like
I'm
voodoo.
doing
It was
this
like
because
voodoo
I think
medicine.
yeah, I'm doing this because I think it's one of the safest, best ways. It's how I would want to treat myself. So tell me how you got involved with sublingual allergy immunotherapy. Was it from the meetings at the AOA or something, or was it somewhere picked it up or?
Yeah, definitely. And I think you saw me. I think I was on Cab TV. I think that was the year I got onto the Cab TV.
Yeah, no, I think it was on
I
Main
got
Street.
so yeah, I got into sublingual immunotherapy while I was still in private practice. When I had the allergy practice in my
Oh,
private practice
really? Oh, okay.
in Hudson Valley. Yes, I
Hmm.
definitely learned about it through the coursework, the fellowship coursework I did through the
Right.
American Academy of Otolaryngologic Allergy,
Yes, yes.
and
Hmm.
it made total sense to me to add on another option because not everybody wanted to go through shots.
Right.
That's a thing. It's a big hit to the time, to the schedule. It comes with risk. Kids didn't really want to do it. Parents didn't want to do it.
Right. Yeah. I mean, I survived all of these. I hope they should. Like an anniversary. It's over 100 years. It's been
Yeah.
around, and I always, just quickly too. Whenever I give lectures, to a group of doctors that are skeptical or wondering about things, I like to put up 3 slides. I always put up the first slide. I put up a picture of a cardiologist from the 1940s, showing him with a stethoscope examining a patient, and split screen showing on the other side, the latest echocardiogram and all his new machines. Then I show another picture of an ophthalmologist with his ophthalmoscope looking in the eye of a patient, and then I show in the 1940s, and I show a current optical, the new laser technology. Then I show a picture of an allergist in the 1940s with his long white coat and his needle in his hand, giving an allergy shot. And then I show again 2020 an allergist in his white coat giving a needle, into the arm. I said, "What's wrong with this picture? Why
Yeah.
is this area of medicine not changed?"
Well,
And
I know exactly what I discovered when I went into allergy and I started training and I saw what was going on. I said, something's here. I
it's a
mean, there were a
time
lot of
warp.
low-hanging fruit
Yeah,
that
it's a
needed to
time
be
warp. I
addressed.
mean, it's like Rip Van Winkle. You could wake up and like, no, nothing's here. What
Yeah.
when does that happen? But well, what do you? Yeah, I'm just again, both have probably treated thousands of patients with sublingual immunotherapy, and I've been impressed how safe it is and just how many people have benefited from it. What's been your takeaway? And what I don't know, what do you tend to really find it works well for, like pollen, mold? Dander, is there any areas you have issues or you injections?
Yeah, I mean, it works well for all the airborne allergens. I find it very helpful. Always the challenges for me. Always cat allergy is always a tough one. I find you have to treat with a little more extract.
Absolutely. No, I agree with you. I have two veterinarian patients. They were in veterinary school. Can you imagine they were allergic to cats, dogs, and horses? and I
Oh,
desensitized both of them. And yeah, I had to go to high doses on them, but it
yes.
worked, so
I find really helpful.
yeah.
Great for people who are sort of young on the go, kind of people like
Yes.
you and I.
Let's come to an office every week. I mean, you get seeing the doctor. I love the fact that it's a home-based program.
Right,
And
right.
of year, and I don't know too. I don't know if you know. I book years ago. It was about 12 years ago, about called the Allergy and Asthma Solution,
Mhm.
and I talked how I ended up getting in sublingual shots because I was a classically trained allergist, and I
Yeah.
was giving shots every year, and every year a few people would have an anaphylactic reaction. And I always remember the story when it was in 1998. I had a patient, a young woman, 25 years old. It was a beautiful spring day like today, I shot to, and she had a severe reaction. I went with her to the hospital, took a couple of epinephrine shots, and she recovered. But I was shaken up, and I was like,
Yeah.
there's got to be a better way. I say, I wrote a story in the book that, I was fortunate. It was almost like serendipitous that I read an article in an obscure journal talking about sublingual drops. And I'm like,
Hmm.
why aren't we exploring this? Why would I have not heard about it?
Yeah.
Of course, it always goes back to, oh, the insurance company doesn't pay for it at the time, even
Right.
though it's safer, better, and the patients love it because it's a home-based program,
Right.
so
And it's personalized, so it can't be FDA,
yeah,
approved. But yeah,
yeah.
I found the same thing with shots. I mock them. I mean, they very effective,
Yes,
but
yes,
it's
they are.
but it's strange to have, that's not going to kill you, but a treatment for it that potentially could.
Yes, that's what I struggled with, and that's why, over 20 some odd years ago, I switched my
Yeah.
entire practice. I haven't given an allergy shot in over 2 decades. So,
Yeah. Yeah. I think at the end of the day, it's just great to have options, to give
absolutely.
options.
Yeah,
Some people want to come into the office to get injections, and
that's
that's
true.
great. But then some people that's just not good for.
Right.
Likewise, you give them a treatment to go home with, and
And
they
they
never do it. They forget it.
Right,
So they're
right.
better to come
I
into the
was
office.
worried about that when I first started doing it, but I found tricks. Like I always patients, like I said, bottle next to your toothbrush. I said, hopefully you're gonna
Yeah.
brush your teeth every day. And the patients, they wouldn't even admit if they don't, but they, some of them do it.
And as you
And
know, I've gone one step further.
yes, we're gonna get to that. Yeah. So let's have Dr. Reisker put on his business hat because aside from
Yeah.
being a professor at Weill Cornell, he's also involved, as I mentioned earlier in the podcast. He's founded and he's like medical director of like 4 companies: Elevate, Intraimmune, Novoplexus, and Easily Healthcare. So tell me a little bit about the companies, whichever order you want, and I want the listeners to know about Allerdent also, because I've been familiar with it for a while. It's fascinating. So give us a little bit of education on this.
Yeah, I'm exhausted listening to you describe what
I
I
thought there
is.
had to
Yeah.
be more than one founder, but I'm like, no, Bill's doing all this in his spare time at night.
As
Now,
if I wasn't busy enough, just like taking
right.
polyps out of people's noses. Now I had to found a bunch of companies. But the technology, the companies that I work with and that I co-founded really came out of my clinical practice. The unmet needs that were going on and really pain points that I was experiencing. So at the end of the day, these companies are all designed to make me feel more comfortable. I had while sublingual was really taking off in the practice. There were some difficulties with people adhering to the schedule from home, so that was a pain point for me. So that led to the therapeutic, which I'll talk a second. And I had issues with some of the diagnosis where people really thought they were allergic, and I thought they were allergic, but their skin and their blood testing came back negative, and that ultimately
Mm,
led to the brush biopsy and the assay I developed here at Cornell and patented, and then that led to the company Immunivent,
wow.
which was able to commercialize that test. So yeah, so the companies are in the allergy space, diagnostic and therapeutic as well. Novoplex, digital health tech. So I jumped into the tech world, and that is still a work in progress. We're working on bringing price transparency to the consumers, to healthcare
Yes, that is
consumers.
an important thing. I mean, all of us,
Yeah,
we just it's a heartbreak. The fact that patients can't, myself can't get in. You pay a lot for insurance. You get so minimal, either your doctors, that's affected the whole system. And it
yeah.
just doesn't seem right. We with all of our technology, you would really think that we could have a better solution to this.
A good idea for a future podcast, a whole
Yeah. Oh
conversation just
yeah.
on how we fix this broken healthcare system.
Yes. Oh yeah.
But with the where Allerden came from, which
Yes.
is the
You
toothpaste.
explain. Yeah.
So this came directly from my experience with sublingual immunotherapy. I had problems with some of the younger kids doing the drops. They just didn't want to hold them under their tongue, and it was
Right.
hard for people to remember to do it.
Right.
So, and of course we know that the oral mucosa, the lining of the mouth, is so rich in immunologic reactive tissue that I
Yes.
felt like I was leaving a lot of real estate behind, right? So a lot of those factors came together, and I said, well, how can we deliver these extracts to the lining of the mouth in a way that integrates perfectly with the daily routine? And so
Right.
then I set about to develop a toothpaste delivery system, some way that we can actually incorporate the extracts,
Right.
same ones that we do for slit and
Yes.
and get them delivered while you're brushing your teeth. And that led to a lot of research and development to try to find something that was able to do that. It took a lot of work to actually do that. And we did some studies that were funded by New York State, and we studied that compared to sublingual, and we found that it worked really well. And then the clinical practice started building around the country, and now there's probably about 1,000 people around the country who are using Allergen for their respiratory allergies,
Wow.
just like they use sublingual immunotherapy.
Right.
And now there's one of the companies that I work with, Intramune, is actually going through the FDA approval process, studying it for peanut allergic individuals
Mm.
to see if we
I,
can
you know,
develop.
I actually, I didn't know if you know, I've been sublingual for the foods the last 2 years.
How have you been
And
finding
because,
that?
yeah, Edward Kim, I have him on the podcast, and Carrie Nadeau, they've been doing it. Also, it's safe, for obviously a dangerous
Yes.
potential patient. And the literature, real efficacy. So it's great that you're working on that too,
Yeah.
because that also, as we both know, is such a huge impact for especially young people in the country. Like listeners too, I always find this fascinating when I give lectures on sublingual. Is I always like to show this picture of an Indian, an American Indian, and then people I look like, why is he showing that picture? And I like to show that it was fascinating, like where this whole idea of immunity in the mouth comes from. That the Indians had figured out, as you may know, that when they used to lick the leaves of the poison ivy, they wouldn't get poison ivy, and in fact, it would
Ah,
protect them when they were running through the woods there from
yeah.
getting it. So it's so interesting how the mouth, or you're saying oral mucosa can develop immune tolerance. And
Yeah. It's sort of the best classroom you could ever ask, because
mhm,
if we put inside our mouth, I mean, usually, I mean, it's a lot of things in their mouth that they shouldn't, but
right,
typically the things we put in our mouth were the things that our body was supposed to accept, things
right,
like food, for example.
right.
Whereas the things that penetrated through your skin, usually bad players. So those are things that the immune system has to learn how to fight against.
Absolutely right. Yeah.
Yeah. So we really just exploit that the body's ability in the mouth to teach the body what it should tolerate. And that's exactly what we're doing. It's a
Yeah, I
perfect
mean,
motif.
I think you're so innovative, and again, having more options for all various types of allergic
Yes.
patients, I think is incredible.
Right. It's not a one size fits all. Not every treat for every person.
Hmm.
A restaurant, if it only had one or two things on the menu, right? You want some options.
Yes, you want some variety.
Right. Some nights you feel like pot roast. Some nights you feel like chicken.
COVID front, are you seeing, thing with patients, getting anosmia, sense of smell, and I got the term for losing their sense of taste. Guzia, I think, is losing their taste. Are you guys seeing this in the clinics there? I mean, the practice is severe as we're hearing.
Yes, absolutely. And this is such a devastating condition to happen to people. I mean, we see people have regular colds. They get a lot of nasal symptoms, and then they can't taste as well or smell as well because of that.
Right.
But people who are suffering from COVID, even before they've developed any nasal symptoms, they're finding that their sense of smell and taste has gone out. And you don't realize how much you rely on that for your quality of
Yes.
life
Oh,
until
yeah.
it's not. It is so devastating. Thankfully, most people get it back, but boy, for some people it can take a long time for it to come back, and it's really
And
difficult
it's
one
hard
time.
reading. It's not even also just even the loss of taste and smell, which is bad enough like that. But some of the patients, even when they're eating foods, the foods just taste like really horrible.
Yes,
Yeah,
yes.
you
Some
know what I mean? So
people,
just throw like I've heard stories like gasoline, and I mean just crazy
oh,
stuff. And we can be more research into that, which would be great.
absolutely.
Um, so to wrap up, too, I also I'm going to start a new thing. I'll start it with Dr. Bill. Is there anything you want to ask me? Is there any question you want to that maybe you had on your mind? I'll throw out to you.
Well, I guess how do you see the future of healthcare going? Do you see that getting better? Do you see doctors having more power? Do you see
Uh,
patients having more up in the
I
healthcare
I
system?
think the latter. It's interesting because I do give a lot of thought to this, and I think it's what's going on in the whole world in every aspect. I think patients are so much more empowered, which is exciting.
Yeah.
They come in now and they get their labs faster than I get it. It's on their phone. Oh, here, Dr. Mitchell, I have the labs that you ordered, and we're looking at it together. I like the patients. I love, the fact that honestly, that on the internet they can get a lot of information, so that we're talking on a very even level. It's not like the doctor's on the pedestal anymore.
Right.
What I like to share with them is I say, like, I just hope I'm taking care of thousands of patients that have had particularly their condition, that I have at least experience to guide them through it. But I think there's going to be a lot more patient self-empowerment. That's what they want. And I think, our as doctors, I don't think we're going to be going away. I mean, people need doctors. I think we have to change in our role, in the sense that to really bring that value to a person that's going to spend their time and their money with us.
Yes.
And telehealth has been helpful too, because again, what I'm telling patients also is interesting. I've been doing around the country a lot of telehealth consults, since things have opened up with COVID, and it's
Mhm.
actually pleasant because, like in this podcast, and this, see your face. When people are in our offices, they're all masked up and everybody's mumbling through the masks. It's actually, for the first visit, it's not so bad doing a telehealth.
Right. Right.
So
Yeah.
that's what I see.
I think healthcare is still very episodic. We see at one point and then we don't see them for another 6 months. We don't really know what happens to them or what they're doing or what their health is like in
Yeah,
between.
that
I think
needs it too. You're right. I think
yeah,
that, and again, I think that with the whole thing with whether it's apps or algorithms,
yes,
and with alerts, or patients get alerts. I think that's all where, I mean, really good
yeah,
companies. I'm not into this, but I love to have my mind. I think of these ideas, and I think that's where there'll be tremendous improvement in
yes,
our health, and because people are interested, they really want it. I mean, I'm so many patients that I see, they are real advocates, and so it's no more being a passive patient anymore. The PP is gone,
mhm,
and so hopefully the next generation of doctors that we've been training will be open to that and realize that's where things are going.
yeah.
So
I think so. I mean, they're going to be on board with technology, and
yes,
and I think they're going to be willing to work with technology companies to
yes,
figure
yeah,
out
that right. There could be
how to
that
create that
partnership.
that ribbon of care. So
Yeah,
if there's a care with your patient.
yeah. Well, this was great. It's so great seeing you again,
Yes,
and I
great
feel
catching
like
up.
this turned out to be the spirited discussion that I was hoping for.
We
So
could probably
thanks for.
go on a few more hours if you
We
want.
may have to do a sequel to
We'll
this,
do a
but
sequel, definitely.
I'll let you go back to your practice and your multiple companies, and please keep me on your list when Stand Up New York and those places open up again. I want to see
Absolutely.
my favorite doctor comedian in person.